This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Child's Nervous System, published in 2026. It's a systematic review focusing on the use of the Ventriculosubgaleal Shunt, or VSGS, specifically for post-infectious hydrocephalus in pediatric patients.
This is a timely review, Alara. Post-Infectious Hydrocephalus, or PIH, is arguably one of the most challenging conditions we manage in pediatric neurosurgery. Unlike post-hemorrhagic hydrocephalus, PIH often involves a massive inflammatory response, high protein levels, and loculations that make standard shunting a nightmare.
Exactly. And the authors of this systematic review really dive into whether the VSGS is an effective bridge or even a definitive treatment in these cases. For our listeners who might be early in their residency, could you quickly remind us why we don't just go straight to a permanent ventriculoperitoneal shunt in these kids?
Right. If you put a VP shunt into a child who still has active meningitis or extremely high CSF protein, that shunt is going to fail. It'll clog, it'll seed the peritoneum with infection, and you'll end up in a cycle of revisions. We need a temporary solution to decompress the ventricles while the infection clears and the CSF chemistry normalizes. Historically, we used EVDs or Rickham reservoirs, but the VSGS has gained a lot of traction.
And that's what this paper investigates. The review synthesized data across multiple centers to see how the VSGS performs specifically in the post-infectious cohort. One of the most striking points they make early on is the versatility of the subgaleal space for CSF absorption.
It's a clever space. You're essentially creating a temporary physiological reservoir under the aponeurosis. What did the study find regarding the primary outcomes, specifically the rate of conversion to a permanent shunt?
The data suggests that while VSGS is intended as a bridge, a significant subset of these patients, around 15 to 20% in some of the reviewed cohorts, actually avoided a permanent VP shunt altogether. The theory presented in the paper is that the VSGS might allow for the reopening of natural CSF pathways by keeping the ventricles decompressed during the healing phase.
That's a holy grail outcome in PIH. But we have to be realistic. For the other 80% who did need a VP shunt, what was the bridge duration?
The systematic review found an average bridge time of about 4 to 8 weeks. This period was crucial for allowing the CSF protein to drop below the threshold, usually cited as 200 milligrams per deciliter in the paper, and ensuring multiple negative cultures. By the time they moved to a VP shunt, the failure environment was significantly mitigated.
Let's talk complications. In my experience, the VSGS isn't without its headaches. Skin breakdown and CSF leaks are the big ones. What did the review say about the safety profile?
You hit the nail on the head. The review identified CSF leakage through the incision as the most common complication, occurring in about 10 to 12% of cases across the studies. However, the authors noted that this was often related to surgical technique, specifically the need for a multi-layered, watertight closure of the subgaleal pocket.
And what about infection? It seems counterintuitive to put a foreign body into a space that was just infected.
Surprisingly, the secondary infection rate, meaning a new infection introduced by the VSGS itself, was quite low, hovering around 5 to 7%. The authors argue this is actually lower than the infection rates we see with external ventricular drains, or EVDs, which are open systems. Because the VSGS is entirely internalized, it minimizes the risk of ascending tracts from the skin surface.
That's a major point for the residents listening. When you're choosing between an EVD and a VSGS and a neonate with PIH, the closed nature of the VSGS is a massive advantage for nursing care and mobility. You don't have to worry about the drain being at the level of the tragus every time the baby is moved.
Exactly. The paper also touches on the subgaleal pocket itself. One of the technical insights from the systematic review was that the size of the pocket matters. If the pocket is too small, the pressure doesn't dissipate, and you get that skin necrosis you mentioned. If it's large enough, it acts as a much more effective absorptive surface.
Did the study address the debris issue? PIH patients often have very chunky CSF, fibrinous strands, and purulent material that can easily occlude a small gauge catheter.
It did. The review found that catheter occlusion was more frequent in PIH compared to post-hemorrhagic cases. They suggest using a larger bore ventricular catheter when possible, but interestingly, they noted that even if the shunt occludes after 3 weeks, the damage control phase might already be over, and you might have already bought the brain enough time to avoid an emergency decompression.
I want to pivot to the surgical timing mentioned in the review. Did they find an optimal window to place the VSGS?
The consensus in the review was early but stable, placing the VSGS once the acute phase of the meningitis has been treated with at least 48 to 72 hours of targeted antibiotics, but before the ventriculomegaly causes significant cortical thinning.
That's always the balancing act. Now, let's talk about the conclusion of the review. How does this change our practice in 2026?
The authors conclude that VSGS should be considered the first-line temporary diversion strategy for PIH in infants. It has a superior safety profile compared to EVDs and provides a more reliable bridge than repeated fontanelle taps or Rickham reservoirs, which carry the risk of repeated needle tracks through the brain parenchyma.
I agree with that. The fontanelle tap approach is becoming a bit of a relic because of the risk of porencephalic cysts and secondary infections. This systematic review gives us the evidence base to say that VSGS is not just a backup plan, but a primary strategy.
One final interesting point from the paper. They looked at the economic impact. While the VSGS requires an initial trip to the OR, the reduction in ICU stay and the decreased need for daily sterile procedures compared to an EVD actually made it more cost-effective over a 30-day period.
That's a factor we can't ignore in modern hospital management. It's better for the patient, safer for the brain, and more efficient for the system.
Exactly. Before we wrap up, Eris, any pearls for the residents who might be performing their first ESGS after reading this study?
My biggest takeaway, which aligns with the paper's findings, focus on that pocket. Bluntly dissect a wide space in the subgaleal plane, well away from your skin incision. If your incision is directly over the pocket's highest pressure point, it will leak. And as the review emphasizes, a watertight, double-layered closure is your best friend.
Great advice. That covers the major findings of this systematic review on ventriculosubgaleal shunts for PIH. It's a robust look at a procedure that is clearly saving a lot of cortical tissue in these vulnerable patients.
Excellent summary, Alara. To our listeners, we highly recommend reading the full text in Child's Nervous System to look at the forest plots and the specific inclusion criteria for these studies.
Thanks for joining us. We'll be back next week with another deep dive into the latest neurosurgical literature.
Until then, keep learning and keep operating. This is the Neurosurgery Hub podcast.